Welcome to the Woodrow Wilson Center. My name is Jeff DeBelko. I have the very good fortune of being our coordinator of our Global Health Initiative and director of our Environmental Change and Security Program. So on behalf of my colleague, Kaylin Ostrowski, who is my partner in crime on our Global Health Initiative, it's a real pleasure to welcome you all today to a session that is really all Pathfinder, really organized and made this possible. And we're just pleased to be able to host it in our facility here at the Wilson Center. It's terrific, been partnering with them. And we're really looking forward to a session that we've entitled Reality Check, Challenges and Innovations in Addressing Postpartum Hemorrhage, a critical topic that warrants this kind of attention, doesn't always receive it, but we're so pleased that Pathfinder is really making it possible for us to have this discussion today and that you've joined us for it. This meeting from the Wilson Center perspective is a terrific opportunity for us to continue and extend the conversations we've had on maternal health in partnership and with the support of the Maternal Health Task Force and UNFPA, an initiative that we did all of last year and plan to continue this next year. So it's a thrill to have this in that continuity in terms of addressing these topics, and it's good to see a number of folks who participated in those sessions return and join us again. The Wilson Center, just a word if you allow me for those who may be new to the center, is actually the formal memorial to Wilson. So in 1968, Congress set up a living memorial to reflect his legacy as scholar and politician, the only president to have a PhD. And so in that sense, we have the practitioners and the researchers coming together to learn from one another on a nonpartisan, non-advocacy basis. And so we welcome you all to this forum. Hope you will, throughout the day, take advantage of some of the materials you'll find for the Wilson Center around the center, and please do come back. Specific for the materials for today, obviously those of you here can pick them up out front. Those of you who are watching on the live webcast, you'll be able to find the agenda, the PowerPoint slides and such on the website, as well as a couple email addresses where you can email questions that can be integrated into the conversation over the course of the day. So please do take advantage of that. And of course, for folks who aren't able to watch it live, the video will be archived on the Wilson Center Global Health Initiative site, so we can direct people to those later on. So I think that is my quick duty. I'm going to turn it over to May Post from Pathfinder to really get us started on the substance of today. So once again, welcome to the Wilson Center, welcome Pathfinder, and welcome May.
Good morning. I have been asked to serve as the MC for this event. I'm honored to stand here on behalf of Pathfinder International to welcome and thank everyone for joining us here today at this exciting event. All of us here are fighting to reduce maternal mortality. Postpartum hemorrhage is very important since it contributes to at least 25% of maternal deaths. We have lined up an array of experts from a range of organizations who will share with us innovative models, proven practices and interventions, and in-country experiences. At the end of each presentation, there will be a short reality check session on the real challenges that we face in addressing maternal mortality due to PPH. For example, we all know that the non-pneumatic anti-shock garment works to stabilize women and increase her chance for survival. But in reality, are systems in place for the next steps? Are systems in place to ensure that application of the anti-shock garment is the end of the story? Because it should not be. What are the challenges, the barriers? So we will all try to discuss these issues and challenges and barriers at these reality check sessions. We have a full day ahead of us, so without further ado, I will introduce the next speaker, Cathy Solter, to talk about Pathfinder International's innovative model, clinical and community action to address postpartum hemorrhage. Cathy Solter has more than 30 years of international clinical training and management experience in family planning, reproductive health, and maternal and child health. Ms. Solter is a nurse midwife and holds an MPH from the Boston University School of Public Health. She has directed reproductive and maternal health programs and conducted extensive trainings in Afghanistan, Brazil, Ethiopia, Indonesia, Pakistan, and the Philippines. Prior to joining Pathfinder, she managed a UNFPA-funded program with the Department of Health in the Philippines. Until recently, Ms. Solter was the Director of Technical Services for Pathfinder International, where she provided overall technical guidance to Pathfinder programs worldwide. In June 2010, Ms. Solter was named a Senior Fellow, and in this capacity, she continues to provide direct technical support to ensure the quality of Pathfinder programs worldwide. Please welcome Ms. Catherine Solter.
I think that we all understand the 4 delays that occur in responding to obstetric emergencies. The first delay is on the part of the woman, her family, or her birth attendant in recognizing an obstetric emergency when it occurs. The second delay is the slowness in deciding to seek emergency care, and it's often affected by the families trying to figure out where to go and how to pay. The third delay is in actually reaching the facility. The fourth delay occurs at the facility, which may be poorly equipped and staffed and unable to provide the necessary obstetric care. The model for clinical and community action to address postpartum hemorrhage was developed by Pathfinder to address these 4 delays and more. The first part of the model that you see on the top, the blue part, incorporates all of the things necessary to earn government support. Sudhir, one of our panelists, will be discussing this in much more detail. Governments are the gatekeepers. They can provide support, they can facilitate the implementation of programs, or they can block them. Governments are responsible for the development of policies and legislation. They create the standards for things such as the use of misoprostol, or even what procedures to follow in blood banks. They decide on what medical personnel are allowed to do or what they're not allowed to do. They can give or delay permission to work with traditional groups like patent medicine vendors and traditional birth attendants. They regulate pharmacies. They allow the introduction of new innovations and technologies such as the non-pneumatic anti-shock garment, the NASG, that both Paul and Suellen will be discussing, or the balloon tamponade, which you'll hear more about. Governments give permission to do research, and they ensure the availability of commodities. Governments determine certification for both pre-service and in-service education. And most importantly, governments are responsible for the scale-up of innovations, like the active management of the 3rd stage of labor, and the quality of these innovations, which Debbie will be talking about. Blammy Dow will be discussing how to take innovations from the government level to the PHC level. The center section of the model, the orange section, incorporates clinical interventions for the prevention and identification of postpartum hemorrhage. Clinical care begins with the prevention of postpartum hemorrhage through prenatal care and through planning of safe deliveries. Prenatal care is the opportunity for helping plan a safe birth and for giving out safe birthing kits, and for those delivering at home, and for giving misoprostol to be taken after delivery. It's also the opportunity to do screening for the very few predictors of postpartum hemorrhage, such as postpartum hemorrhage during a previous pregnancy or following a previous pregnancy. During the deliveries, AMSL is the intervention that can reduce the incidence of PPH by 40%. During and after delivery, accurately measuring the amount of blood lost is so difficult for providers, and yet it's essential in managing postpartum hemorrhage. Shabnam is going to be talking to you about some of the innovative ways to do the accurate measure of blood loss and to make it more accurate. The correct management of postpartum hemorrhage includes the appropriate use of uterotonics and fluid replacement. One of the best ways to get providers to manage postpartum hemorrhage correctly is through the use of clinical drills. Suellen will be discussing how we use clinical drills during training to sharpen the skills of clinical providers. And Jennifer will discuss the correct dosage of misoprostol for treatment. Through our own work in postpartum hemorrhage, we found that obtaining blood for transfusion and getting the surgery necessary to save lives are the most difficult challenges that we face. And Farouk will be discussing some of these challenges and present some of the solutions. At the community level, is where we tackle the 3 of the 4 delays. We create an enabling environment for tackling the 3 of the delays by working with religious and community leaders and by working with community-based organizations. We raise awareness in the community by discussing postpartum hemorrhage prevention, danger signs, and the community response. I like the way Sudhir describes this when he says, we saturate the community with health messages. It is at the community level where we make the linkages to prenatal care for birth planning, and we hand out safe birthing cards. We advocate for the use of skilled birth attendants and for delivery at facilities where appropriate. Community-based referral systems must be in place to link the communities to the facilities. Community transportation systems must be put into place and must take into account the form of transportation used, the money necessary, saving schemes to have money available, who provides the transportation, and who initiates the system in case of an emergency. In each country where we work, we've implemented the CCPPH model in a different way. Nigeria was the first country where we implemented the various elements of the model. In fact, the model was developed based on our experience in Nigeria. In addition to scaling up in 7 states, the clinical interventions were incorporated into the pre-service education curriculum for midwives and to the National Midwifery Scheme that deploys retired and unemployed midwives back to the PHC level. The India project focuses on the integrating technical innovations into the public health system and investing in frontline workers and change agents. The advocacy done in these countries was very different. In Nigeria, research on the NASG had already been done for several years. So it was readily accepted by the government. In fact, they couldn't wait to get their hands on the NASG. Whereas misoprostol, another intervention that we were trying to introduce, had not been used widely in Nigeria, and there was a lot of resistance to that. India was the exact opposite. Misoprostol had been there and used, and people were comfortable with it, but not the NASG. So our experiences in these 2 countries were completely opposite. In Bangladesh, the project focuses on empowering families and women to incorporate new technologies at the community level for home deliveries. In Tanzania, the model has been implemented in a camp containing 38,000 Congolese refugees and the communities surrounding the camp. In Peru, the project has focused on advocacy with the government and with the OBGYN Society to convince them of the efficacy and the safety of the NASG. The CCPPH model is a comprehensive, practical, and adaptable model. The elements of this model taken together can have a significant impact on maternal mortality, but the elements implemented individually have far less impact. The model can be adapted for other causes of maternal mortality, such as preeclampsia and eclampsia or sepsis. You've all received a folder, hopefully on your way in. The folder contains the PPH curriculum, a training video, some job aids, and a community survey tool and data collection instruments. Thank you.
Thank you, Cathy. Our next speaker is Dr. Sudhir Maknikar. As Cathy explained, one of the building blocks of Pathfinder International's clinical and community action model to address PPH is government support. Dr. Sudhir will present his in-country experience on related to government support. Dr. Sudhir Maknikar is a senior public health professional who is a trained physician with a specialization in community medicine. He has more than 10 years of public health experience in India in the areas of family planning and maternal, newborn, and child health care at the district, state, and national levels. Dr. Maknikar has successfully designed and implemented capacity building programs for improving service delivery for family planning MNCH. He joined the Pathfinder India country office as project leader with the Raksha PPH project, where he provides strategic leadership and managerial oversight. He also serves as the point of contact with the Government of India and supports fundraising and program performance. Dr. Sudhir.
Thank you. Good morning. My topic is advocating with government officials to promote enabling policies. Continuum care project. In India, we call this a Raksha project because we do branding for each and every project in the Pathfinder India. Raksha is a Hindi word that is called as a protections. The Raksha project, which is started in India in 2008 in the 4th state. If you can see this, Rajasthan and Bihar, two underdeveloped states, where high MMR state, where 388 and 32. India MMR is 254. And the low MMR state, Maharashtra and Tamil Nadu. So these are the 4 states we have started our continuum care projects. These are the 4 strategies we are addressing for the clinical and community actions to address the PPH, where India still there are 30% of maternal death is because of PPH. What is government? You must be thinking Indian government system is hierarchical, highly regulated, under-resourced and underperformed. But you are right. But that situation is 10 years before. Now the situation has completely changed. You can see the funding. The government has increased funding from 2 billion to 4.7 billion USD now. NRHM is National Rural Health Mission, which is started in 2005. There is a strategic shift in human resource management. There is multi-scaling, task shifting. There is 24/7 services available in first referral unit. You can see the budget from 2005 to 2009. Along with the budget is increasing, the institutional deliveries are also increasing. This is 10 million institutional deliveries. In 2005, it is just 0.7 million. That's it. What we want? We want skilled birth attendant at the deliveries. India at present, 50% of deliveries are happening at the institutional level. That means almost we have done the 50% target has achieved. The still 50% are happening at the home level. But along with the expenditure, the performance of the facility is also increasing. So there are lots of other issues. Decentralized planning, flexible financing, equity and convergence are the important strategy for the MRSMs. So now the government has, we can't take it lightly. Government is a vital partner. It's not a recipient. So these are the three elements for the successful advocacy. Engage government from the outset, toolkit and champions. So how we have identified these three elements is a successful strategy for enabling, to change the enabling policies in the government. Like globally, even in India, maternal mortality is not a priority issue as compared to other health problems like child survival, HIV, AIDS and tuberculosis. Reason is so obvious because maternal death is not so common as child death. Like globally, there is 8 million deaths, child deaths, 1.7 million deaths because of HIV and 1.8 million deaths because of tuberculosis. And only maternal death has less than 0.5 million deaths. So that is why it is very difficult to get the recognition of maternal health problems. Second is, it is very difficult to measure the impact of the program. We are still confused between maternal mortality rate or ratio. So how to, that problem has to be addressed to policymaker. It's very difficult and challenging. Like infant mortality rate, we are easy to measure, but maternal mortality, it's very difficult to assess the impact. And third is about intervention. Necessary interventions to prevent maternal death are not available. Like vaccine is available for vaccine preventable diseases, sterilization is there for family planning methods, but for maternal health, there is no effective intervention, simple effective interventions available at the community level. So with this, we have involved the government since beginning. There is a simple toolkit for the implementation of the program, and we have identified the champions to promote advocacy for our products, innovations, and ideas. So what are the steps to engage the government from the beginning? So in the pre-design state, we have reviewed all the existing policies. There are so many policy gaps in our country regarding maternal health. There is SBA policies, which is, there is a, for example, there is a lot of confusions whether to antibiotics or oxytocin or misoprostol is given by the midwiferys or not. Previously it was not, but now the policy has changed. Now all the drugs are ANMs or midwife can give. So such type of policies we have reviewed it. We have ensured the balance between government interest and our priorities. The government interest is comprehensive emergency and essential obstetric care. Government is promoting institutional deliveries, but our priority is PPH, postpartum hemorrhage, and NSG. So we have ensured that balance since beginning. So in the design state, we have consulted so many meetings to convince all the partners and stakeholders about the outlining our elements of Raksha project, PPH projects, and their rationales. And the important is I want to highlight here the evidence-based interventions. What are the evidence-based interventions? Active management of third stage. Globally, everybody knows there are plenty of evidences. NSG, now there are so many evidences are available with the anti-shock garments. So these are the two evidence-based interventions available to prevent maternal mortality. This is important feasible indicators. To work with government, it is very challenging and difficult to get the information, that is quality information and data. Because there are so many complex formats we give to the government to get the collect informations. So what are the feasible indicators in our project is we have identified 3 feasible indicators. That is one, active management of third stage labor, how many facilities they follow the AMSTIL. Second is about case fatality rate because of PPH. Instead of maternal mortality rate and ratio, it is very easy to analyze. It is by the case fatality rate and proportional mortality. What are the trends? And third is about birth preparedness and complication plan available at the community level. Our target is each and every pregnant woman and decision maker should know what is a birth preparedness and complication readiness plan. So we have identified these 3 feasible indicators. In the implementation, we have identified and built relationship with the concerned nodal officer at the state and district and the national level. The technical assistance, of course, we have given the technical assistance for training and monitoring and evaluations. Periodic dissemination of evidences. It's the same like what we are doing here today. It is dissemination of evidences. So we do disseminate our evidences, best practices periodically in the conferences and everywhere to get the attention of all the policymakers over this hidden issue of maternal mortality. And there is appropriate touch points during the government. We do monthly meeting in the Raksha project, that is project advisory committee meeting, district advisory committee meeting to share what are our monitoring findings. For the example, if oxytocin is not available, then immediately government ensure that oxytocin is available at the facility level. So such are the things we share with the appropriate touch points. During the toolkits, there are products, best practices, and approaches. What is the product? Energy. Anti-shock garments, now there is enough evidences, even in the international journals, articles, Nigeria, Egypt, there are so many studies are available. So during the anti-shock garment, we identified 2 touch points. One is at the periphery, where the shifting time, transfer time for the pregnant woman is not less than 3 hours to shift from periphery to tertiary care. If Pathfinder trained service provider give Amstel and apply the anti-shock garment and refer it to tertiary facility, definitely that woman is going to save. Second touch points at the tertiary level. Even the woman arrive at facility, there are incidences where specialists are not available, like gynecologist, anesthetist, blood is not available. During that arrangement, if garment is applied, definitely that woman is going to suffer. Then we give the Kelly's pad, that is estimation of blood loss. Nowadays, there is no definition for the estimation of blood loss. That is completely subjective and visible. Every practitioner, specialist say, oh, this is PPS, this is PPS. But in our country, that's 80% of pregnant mothers are suffering from anemia. It's even 200 to 300 ml of blood loss, she goes into the shock. So that is why the importance of Kelly's pad is there, and PPS shock kit for the management of shock cases. And we have given the simple job aids, protocols, and the toolkits. Job aids in the labor room, if sometimes midwife miss what are the steps of Amstel, she can use it. How to apply the energy, how to remove the energy, and the protocols for the management of shock. And the simple tools. I want to discuss more little bit about the simple tools because it's related to this very important issue. So this is the simple tools. What we have done for the simple tools, instead of giving so many complex format, we have done just added 2 to 3 columns in the existing delivery register of the government system. So instead of giving too many formats and expecting this, they will share with us because there is resource constraint and there is lots of workload is there. So we have added the columns in the existing register. So this is the result. You can see this. The facility is following the Amstel protocol. It is increasing, and the case fatality rate is from 8% to 1%, and proportional mortality is decreasing from 27 to 6%. So that's the result. That's the importance of feasible indicators and identifying and simple tools. So we have kept in mind, we are with you. We don't demand anything, so we want to work with the existing resources. Task sharing. During our routine monitoring, we have found out the 2 important innovations, that is task sharing and joint supportive supervision. What is meant by task sharing? There is enough shortage of medical officers at the peripheral level. Instead of highlighting repeatedly shortage of medical officer, what we have done, we have trained all the midwifery in the districts. So all the midwiferys are available at the peripheral level, and they are doing excellent management of Amstel and the PPH. Now the number of PPH cases and shock both are reduced because of this innovation. Instead of 5-day training, we have trained all the ANMs on the 1 day, that is orientation sessions. That is alternative training approaches. Other approaches is on-the-job training and hand-holding. And the second innovation is joint supportive supervision approach. What we do, if we do the independent monitoring, what will happen? There are plenty of issues. Unless and until government take action on this, all this independent monitoring findings doesn't make any difference. So we have identified one problem-solving team at the district level, which comprises district level officers, clinical consultant as a gynecologist, medical officers, and Pathfinder staff. They will go and link whether training impact is there, whether performance improvement has improved, or is there any other issues. So they ensures this everything, HR, logistic, and accountability. And so this has important innovations which solve the problem immediately on the spot at the facility level. So champions, what the champions will do? We have utilized the champions at every level very systematically, international to local level. Like we had an international champion, Suellen is there. She had all the evidence of anti-shock garments, plenty of evidences. She provides technical assistance. Local level, frontline worker. National level, there are 2 important champions for us, Dr. Padmanabhan and Foxy President. So they give diffuse intervention of all our products and innovations. You can see the health minister has come to inaugurate the Raksha project, PPH project. We got plenty of attention, media attentions, electronic and print media. So everybody in India, there is, everybody is asking, what is anti-shock garment? We want to know, So that's the benefit of doing this inauguration. Then behavior change. Generally, we use the BCC for the service provider, but we use the behavior change for the bureaucrats or senior officials in the government system. We use champions to change their behavior because there is very ambivalent attitude of senior officials when we launch a new program or new product. Energy, like energy. Everybody is curious, what is energy, sort of. So use the champions for the behavior change, and there is a sustainability scale-up also. So this is evidence. We are working in one district for each of these 4 states. Now we are working in 8 to 10 districts. And government has adopted this PPH model in this product. So Pathfinder trainees, technical assistant, using all the government training programs, collaboration with FOXY. I want to highlight these FOXY collaborations, how it is. FOXY is a Federation of Obstetrics and Gynecology Society, like FIGO internationally, sort of. So in one of the conferences in Bihar, we have highlighted the energy, and there is very senior officials are sitting in the Bihar government. Previously, he is not interested to scale up this project, but the gynecologists from the same state, when they share their experiences, already energy is implemented in the Bihar state, he immediately calls us, I want to purchase the garments. So that is how the importance of collaboration and organization with all this FOXY. Then introduction of all this in training curriculum, SBA is a skill birth attendants, and advocacy resulted in expanded maternal health budget. Now in all the scale-up model, we have incorporated eclampsia and PPH also both. Now to $200,000 USD, the government is contributing to our Raksha model. We are just providing energy and technical assistance. Rest cost is shared by the government. So that is, so along with this, all the success, what are the challenges? To get the sustained attention from the government, it is very difficult because there are so many other health priorities, tuberculosis, HIV, AIDS, polio eradication activities. It's very difficult to get all the time sustained attention for the maternal health issues. Complex products. Complex products is in the terms of Amstel and energy. It is not possible for the home deliveries. Even vaccine, you can take the example of vaccine, anybody can use the vaccine, but here product is complex. Change in officials in elections. When we develop the rapport for any government officials, suddenly the election comes and all the transfers and shifting of all the officers. Again, we have to start from zero. That's the biggest challenge we have faced. All the trainings like crisis, outbreaks and disaster. You can see the pictures here in the Bihar. There is no training for 6 months. There is huge flood and disasters. So these are the obstacles. We are doing everything. You can see the president, health minister, they are interested in polio eradication drive. But the very few people are interested for maternal health. So what? Now you might be thinking in the audience that what is great in it? Is it worth to work with the government with so many complex things? Yes. I will say it is very worth. If you want to really make the policy change, we have to work the government. So you can see the impact and coverage and reach of this scale up in the program. Issue of prominence. Everybody's safe motherhood. People are interested in Amstel and energy. And the collateral benefits like health system strengthening. So I want to end this with it. We have to work together to bring this change. And here is the theme where we are working hard to bring the change in this India country. Thank you. Sorry, I am extending a little time.
I've been told that there's a slight change in the agenda. Instead of the reality check, we will go on to the next presenter. Following government support, the second building block for Pathfinder's model is clinical interventions. And our next presenter, Deborah Armbruster, will talk about use of active management of the third stage of labor in 11 developing countries. Deborah is a nurse midwife with a master's in public health, and she is also a fellow of the American College of Nurse Midwives. In April 2010, she joined AID and is currently a senior maternal and newborn health advisor. She came to AID from PATH, where she was the director of the research project, the Oxytocin Initiative. From 2004 to 2009, she was director of the Prevention of Postpartum Hemorrhage Initiative project. She has over 25 years of experience in safe motherhood and reproductive health programs in over 15 countries. She has been actively involved in the Safe Motherhood Initiative for over 15 years and is a founding member of the White Ribbon Alliance for Safe Motherhood. Please welcome Deborah Armbruster.
I see the faces of many old friends, but what's nice is I also see a number of new people who've joined us. First of all, I want to give Pathfinder a big thank you. I think it's great that they would come to the Woodrow Wilson Center, pull a lot of experts, particularly on innovation, and have a really clever way to be looking at a topic that we've been working on for quite a while, and unfortunately still have a lot of work to do. So with that, let's talk a little bit about active management, which I've done for a long time, but I had fun putting this together because I kind of thought about it in a different way with our reality check and innovation theme. First of all, the 11 countries that we see here and the use of active management, those countries include all of the survey countries that where Poppy conducted the surveys. But in addition, we were fortunate that we put the tools up on the web. That was Cindy Stanton's idea. And we had countries kind of take off and use them. We were able to get the data from Bangladesh, which actually used their funds. It was the Engender Health Project, and conducted the survey. I think we provided a little bit of guidance, but they did it on their own. So Poppy had 10 surveys, national surveys that were done, and the 11th one is Bangladesh. I think Cambodia, they talked to us a lot about doing it as well. We're hoping to do it, and I think some other countries have done it as well. Okay, I have been told way too many times that I need to start with the definition, because we may have people in the room who really don't know when you say Amstel what we're talking about besides a beer. So for a quick definition, Amstel is a high-impact, evidence-based intervention, and as our previous speaker mentioned, there have been many, many studies on this. Two big seminal RCTs 20 years ago, and many since then. We have learned the seminal studies show that PPH can be reduced if you use active management by up to 60%. We've got 3 components. We've got the administration of uterotonic agent, oxytocin as the drug of choice, controlled cord traction, and uterine massage after the delivery of the placenta, and not before, which is actually a problem. Okay, just a bit of history. As I said, the seminal RCTs were done 20 years ago. I think one was 20 years, and then another one maybe 5 or 10 years after that in Great Britain, which meant that the evidence was disseminated out through the Commonwealth. We should take note that the U.S. had never even heard about it, and when Sandy Buffington tried to put Amstel into life-saving skills, she had fights with many, many people because nobody in the U.S. had heard of it. USAID, probably about 10 years ago, created a PPH initiative, and I've always been very appreciative and really felt that was really visionary to try to really bring a focus to active management. And so when Poppy started, that's really what we were working on. But as the data came out on misoprostol, we also added, and USAID is doing this now, a community-based PPH prevention strategy which used misoprostol. USAID has had, even before Poppy, there were 4 projects that worked on active management. Then there was Poppy, and now we've really got active management integrated into many of the maternal health projects. And I think globally, active management, as again our previous speaker said, it's a known topic, and it's an easy sell once you talk to countries who haven't been working on it. So it's really on the global agenda. So let's talk a little bit about these surveys that we did. This is, you can see the countries here, and you can see that unfortunately what we did find is that while active management has been known for 20 years, even when we did these surveys, I should start by saying, because people like, I saw Barbara Kinsey here in the audience, but Japaigo and the work that Harshad, Barbara, and Patricia Gomez had done through the MNH project and probably, the Access project, they said, everybody says they do Amstel, they don't. So we decided, let's see what's actually going on out there, and that's how we even came to do these surveys. They were incredibly powerful on many levels because they really, not only did they give us data, but they were very powerful advocacy tools, and probably the most important thing they did was really get policymakers to sit up and go, what? What do you mean we only have 3%? We only have 0.03%. So you can see Indonesia had the highest rate at around 32%, and Nicaragua had the lowest with, it's actually not 0.3. It's really 0.03. I mean, it's very low. As you go down through here, what we did when we did the surveys, then we had meetings in countries. So what would happen is, like in Uganda, we had, and these are a bit of our reality checks. We found out by holding a national meeting that, in fact, the government hadn't been purchasing oxytocin for a year. And we found this out. You know, the government just was, they were complaining about stockouts, but nobody bothered to take a look that the central medical stores had put out a bid for oxytocin. Nobody took it up. You know, oxytocin's a cheap drug. Nobody wanted to be bothered. So they just didn't buy it. And nobody even knew that. So until we did this survey, nobody had identified what incredible barrier and issue they had until, and actually it was one of the USAID projects, the, what was it, Rational Pharmaceutical Program, Rational Pharmaceutical Management. It was one of their staff that figured this out, and he said, you know, this is unnecessary. Just because they didn't get a bid doesn't mean they can't buy oxytocin. So, you know, one of the other things that would happen is when we had our joint meetings is, you know, we'd find out that pre-service education didn't really have clinical practice on active management, or that the central medical stores had never been talking to the Ministry of Health, the Family Health Division, about what the issues are and whether the providers were actually trained to use active management. So there was a lot of things we learned as we went through. One of the other things we learned, you know, we all are concerned, and, you know, first of all, I should say these surveys were done at tertiary level. We didn't go lower than the district hospitals. So we can't speak to what's happening clear out at the clinics. But take a look at this. So this is using the data and putting it in slightly different format. I don't have a, do we have a, okay. So take a look here. You can see all along here, this is active management. So you can see those are that's the data you saw before. Which one? This one? Okay. So here's active management. And guess what these really tall bars are? 95%, 97%, everybody except El Salvador. 86, 95, 100. That's the use of oxytocin. They weren't having any problem with the drug. It was available, and they were using it. So that was actually a bit of a surprise to us because we expected we'd see more lack of oxytocin. Oh, okay, I'm really going to have to move along here. This is the slide that shows us a really important piece, which is uterine massage. So what we really learn from here is that, in fact, nobody's watching these women afterwards. When do women die? First 24 hours after birth. What happens? They walk back in, pull back the covers, if there are covers, and find that the woman has bled out. And I have a story in the reality check section to tell about that. We learned about the critical elements that are needed if you're going to actually put an active management program into place. We've got, I mean, and many of you have seen this, so I won't spend a lot of time on it, but we need policies. We need, you know, both pre-service and in-service education to ensure people know how to practice AMSTIL. We need the drugs in place, and we need monitoring and supervision, and one of our big challenges is collecting data to know whether we're really having any impact. So what have we learned? What is not so effective is doing any of these alone. And that I think what we've got too often is pieces happening in country, and it's exciting to hear about Pathfinder. They're really trying to pull it all together. And it's one of the things I told Mary Ellen she needed to come and listen to what they were doing because I think it is an exciting program. But we have challenges. And as Sudhir pointed out, we need creative and alternative ways to try to do things like increasing the practice of AMSTIL, ensuring competence. We're going to hear about drills, providing support and supervision, ensuring that the drugs actually get all the way down. And again, in the reality check, I have some comments about, are we even sure we've got potent drugs? Or do we really giving water to these women? Or whether it's water or whether we actually have any active chemicals. And I think something that Mary Ellen has and USAID has been really pushing, and we're getting somewhere, is the whole issue of, do we even know if we're having any impact here? What data are we being able to collect to show that, in fact, AMSTIL is being used and that we're saving lives? So we need some new innovations. We need to engage new partners. We need to recognize the critical importance of the MOH. And, you know, right now, USAID's big project, the MCHIP project, we're working hard on the whole issue of scale-up. So and as I said, we need to look at, I do want to quickly show, because I'm hoping, we had a partner meeting the other day on PPH, that we're going to be working a lot more on, and collaborating on scale up. How do we work together? I think this is a great framework that Steve Hodgins and Jeff Smith have put together. Listing, you can't really see it here, but it's going to be up on the web, and I'll send it to anybody who wants it. The different pieces of active management, and what we hope to do is to be able to identify, okay, this is India. These are the things they're working on. Actually, I think this is Zimbabwe. When we look at Nepal, Nepal is farther along. You know, they've made it, they're really working out on the getting closer to having national scale up. Here we can identify which countries are actually working on these things. So I'm really hoping that we'll all be joined together more often on both how are we scaling up, how are we all working together. No organization can work by themselves in a country. How do we, as Cathy said, have MOH in leadership, all of us participating as we can to ensure we've got scale up. So new and noteworthy. We may find out pretty soon that the Amstel trial, it's a multi-center trial. It's going to report out in early March that cord traction may not even be needed. Maybe we just should be giving oxytocin and doing massage, because that's what they're looking at. What's the importance of the different components? And this is really looking at cord traction. We may, as I said, we may have more of a concern about oxytocin potency than we think. Indonesia, we found that they're using up to 3 vials. Why? Nobody thinks it's potent. They must have a reason for thinking that. I won't bring up another country, but there's some data that will come out in another country soon showing really low, kind of scary issues when they went out to check oxytocin. What about, if that's true, what about Uniject? Will that make it, you know, like a much more viable option, more popular, more people buying it? Should we be pushing misoprostol more often? You know, we know meso's out there. We know it's being used, but is everybody educated on how to use it? I think Cathy or our other colleague brought that up. I think that's a real serious concern. Jen Blum probably will be talking about it because we were talking about it yesterday. We hope you'll come to the big AUDIS meeting. Lots more to learn there. And again, thank you to Pathfinder.
Our next presenter, who will be talking about her in-country experience related to clinical interventions in PPH. The second building block of Pathfinder's PPH model is Dr. Shabnam Shahnaz. Dr. Shahnaz is a senior program advisor for Pathfinder International. She has over 20 years of experience in the development and management of health, population, and nutrition programs. She was previously the country rep for the Pathfinder International Bangladesh program. She continues to provide technical support to the PPH program that she initiated and implemented at Pathfinder Bangladesh. She holds an MD from the Lady Hardinge Medical College, University of Delhi, India, and an MPH from the University of North Carolina at Chapel Hill. She chairs the National Executive Committee of the White Ribbon Alliance for Safe Motherhood in Bangladesh. Please welcome Dr. Shahnaz.
Good morning, everyone. It's really lovely to be here because I see so many friends out in the audience also. What I'll talk about is the project that we implemented in Bangladesh with Pathfinder board funds, and this was really an adaptation of the continuum of care model that Cathy talked about. And we brought in safe birthing kits and misoprostol for the home delivery situation. Just to give a little bit of background about Bangladesh, in most of the deliveries which are taking place in Bangladesh is at home, and it's almost 82%. And of these 82% deliveries, mostly are they are not even a skilled birth attendant to attend them. Every, say, 3 out of 5 deliveries are conducted just by traditional birth attendants or family friends or relatives. And postpartum hemorrhage actually accounts for 28% of the total maternal deaths in Bangladesh. So you can understand the scene in that setting. Maybe you cannot really see the picture that well, the photo, which is that this is a picture that I took on one of my visits when we just started out on our PPH project. This is a woman who had just delivered, and as Deborah was referring to, some of the times they don't even understand they're bleeding and this PPH is occurring. This is a case we were there and we could identify with the family, and the helplessness is very, very clear in the face of the relative. The mother was fine, we got good refer, and the baby was all right. So it had a happy ending. Now to move on, the gap which is happening in the field is the pregnant mother does get to meet somebody or the other, one health service providers, before the delivery actually occurs, whether it's for the child or for herself during antenatal care or a family planning service which they take, or any other services. And after the delivery also, the mother somehow gets in touch with the service provider. But it is during the delivery, the critical 2, 3, 4 hours, when she's entirely on her own, totally vulnerable, just surrounded by families and friends, or an unskilled birth attendant. And this is the most critical time. This is where the deaths are occurring. This is where it all happens. So the window of opportunity is very, very narrow. So this is where we focused on, took the model, took it to the woman, and made the adaptations necessary. We call the project Maya Shastha, which literally means mother's health. And the interventions, we actually did the intervention in a district on a very small scale. I mean, we didn't really want to do it on a very large scale, in the sense that our target was to go out and reach and observe and implement it through 12,000 pregnant women, and in the outcome of delivery, the whole process. This is a very new project. I would say it's just about 1.5 years old. And at this particular point of time, I'm happy to say, after this, we started with Pathfinder Fund. It's now gone into World Bank, has shown interest. They are also continuing with some funds. So the steps in the intervention is effective prevention, which is use of misoprostol, and then active stage of, third stage of labor. Timely identification of PPH, that's postpartum hemorrhage, we're using blood collection mat, and appropriate referral, establish an appropriate referral system, PPH management kit, and use of the anti-shock garment. On effective prevention, of course, there is the counseling, which is antenatal care, postnatal care, prevention and management and referrals. And then there is the distribution of the Maya Shastha PPH bag. As I just referred to, we just extended it and the model to incorporate more other areas that we can address, and that is sepsis during delivery. So what we do in this bag is we have a delivery kit locally made, they put it together. This is nothing new. This is not a new technology. It has been around for years. But so we have this. And then what we have is the misoprostol itself. So we package it. And this is, again, nothing very new. This has been, as Deborah again referred to, Engender Health in country, then other organizations like ICDDRB, BRAC, all of us have been working on it. And so we just put this misoprostol here. And then, of course, we have the blood collection mat. This is for the estimation of blood by the mother and the family. And then we have a referral card. This is really a government referral card. So you can see there's nothing new. There's nothing very difficult. And we just put it all into this red bag. And we give it to the mother. So the mother has it for her own use. And she can actually keep it safe till it's needed for the delivery. And we give this bag to her at 32 weeks of pregnancy. And before that, she goes through a series of meetings and all that to know what is happening. And of course, she has the referral card in the sense that this is just her, has a name and some mobile phone numbers, which helps her get connected to the nearest service provider, whoever is available, and also to the nearest health facility, which has been assessed by us for as a referral center. Now, when I talk about the blood loss, identification of PPH, that is the most critical thing for PPH. And you have to really be able to identify that the woman is bleeding and it will lead to death. And most of the time, women are ignorant. And as Sudhir mentioned right in the first presentation, it's very difficult for clinicians to really understand also how much blood is being lost, because these are all visual estimations. So I've just put up some estimation how it is done. Usually, it's a sanitary napkin, or it is a pad, or just seeing how much blood is being is there, and then maybe it's a kidney dish. How much blood is put into the kidney dish. So usually a kidney dish right at the corner. Is this the one? This one? Okay, as you can see, the kidney dish, when it is really full, we say 500 ml, and that is the time when PPH actually occurs. So others are just different estimations of how you can see it's spilling over to the floor. That means 2,000 ml. So it's very, very subjective, and you can. There are different methods to do it. So estimation of blood loss can be done by the blood collection drape, visual estimation. There's calibrated jugs in Nigeria. There's Kelly's pad in India. And we use the cloth mat in Bangladesh. And there is Kanga in Tanzania. This is just one of the blood cloth mat which is used in different other regions. But this is not what we use, because we wanted something in Bangladesh which can be, women can use it on an individual basis, and then it will be with the women, and they can use it on their own during their own delivery and not be reused again. So the mat that I showed to you, when you put the mat, this mat is usually placed after the delivery under the hip of the woman. And as you can see in this picture, when it is half kind of, the blood comes up to the half level, it's about 250 to 300 ml. This particular mat can absorb 450 ml of blood, and when it goes to the edge, that is actually 450 ml, and that is the time you need to really refer. This is the visual, and it works wonders, because the mother knows that she's bleeding more than she should be bleeding, and of course the family gets to see it's not a sanitary napkin hidden away, or just the woman is covered up and you don't know whether she's bleeding or not. So this is very visual, and this can be it can be estimated very clearly. Now for the appropriate referral, what we do is we have these group meetings where the woman is told, along with her family members, about where to go, how to go, what is the transportation she has to take care of, and the woman is totally in control. These pregnant women are brought together in a group to be told about these activities and events which can happen. The progress so far in this project, I said it's only about 1.5 years old, and the thing is, it's also a very small area. But even then, we have been able to distribute these MyShasto PPH bags to more than 13,000 pregnant women has been registered in this area. We have been able to distribute more than 8,000 bags, and of these, 8,000 women have delivered and used the bag and took the misoprostol. So we have the data of all these 8,000, more than 8,000 women, to the extent where they're delivering, who is there. And you will be surprised to know that, again, the data actually supports the national statistics, that only about 1 or 2 out of all the delivery, out of 5 deliveries are really conducted in presence of a skilled birth attendant. Most of them are done in presence of family and friends. And we also had provided a PPH management kit, which is like this. It actually has oxytocin and also the fluids which is necessary when a woman starts bleeding, and also a condom catheter. So these are really placed in the referral centers we have assessed and identified, and it's not only public facilities, it's also private facilities. So and then of course the orientation and training of all the providers have been given. And the progress so far also on the community level is we had household meetings. More than 21,000 women have really been reached, community group meetings. And we have 2 ambassadors for the project, which is publicly elected representative. And we're happy to say this recently, one of them got a badge of honor, a medal of honor from White Ribbon Alliance Bangladesh for her work in the pre-PH project. At the policy level, this is the change along with the Pathfinder, along with Engender Health, ICTDRB, BRAC, who have been working on misoprostol in the community. We have been able to bring about a policy change in the government that is including misoprostol in the essential drug list, and it's going for a national scale up, and we are very happy that we are all part of it, and we have been able to work together on that. 20 cases of PPH has been managed out of these 8,000 deliveries, and you have to understand only 3 cases have been referred by the skilled birth attendant. Rest has all been referred by the family or the woman herself who took the initiative. And only we had to use the anti-shock garment only once. Challenging is, when I started off this project, understanding of the need to empower pregnant women. That was a big challenge. Why do we have to tell the pregnant women everything? Migration of the pregnant women from their in-laws to their mothers in the time of delivery. Lack of reliable data, insufficient supply of maternal health commodities, maintaining the responsiveness and competence of the referral centers, and of course the financial constraints of families and transportation arrangement. So I'll just finish off by saying that innovativeness and adaptation, it goes a long way, and when we take it down directly to the beneficiary, that is the last mile that really brings about the success in any project. Thank you so much.
Thank you, all 3 of our panelists. We recognize that today we have as many experts in the audience as we do on our panel. So part of our reality check is for you to tell us, and we'd like a discussion. We have 2 mics here. We'd like to take questions, but we'd also like to discuss some of the challenges that you have faced in introducing new technologies, and how you've solved some of the problems. You've heard from some of the panelists what they've done, but please tell us some of your challenges and solutions or questions. Or the panel may have questions for the audience. We have 2 mics here. Yes.
Hi, I'm Suellen Miller, and I have the luxury of being both an insider and an outsider. So I'm not Pathfinder, but I do consult with Pathfinder on this project, and I've had the pleasure and privilege of visiting all of the sites except for the Tanzania site. So I want to congratulate all of you on your talks, and as well as Debbie, and ask just a few questions. So should I ask one question and we can come back to me, or?
You can ask all 3.
All 3 of my questions. Okay, this is for Sudhir. Number 1, you had the simple tools, and you showed very impressive changes in your 3 indicators. What is that based on? What is the data based on? When did it start, and how did? I don't know. Can we go to that slide? It's pretty impressive. Looking at case fatality rate and okay, I'll ask the other questions. Yeah. One is just a comment, and as the person who is doing the research on the anti-shock garment, I can say that we can't guarantee that women who are put in the anti-shock garment will survive. I think that's a very nice thing to say, but in fact, women are put in the anti-shock garment and they can die. It does not prevent death, it reduces death. And my other question was the $200,000 that the government is putting, what government is that, national or one of the states? And those are the questions.
Okay, Sudhir,
Yeah.
they're all for you.
So, yeah. So the slide, you want the slide?
Yeah, and we got the toolkit, but we weren't sure which one.
I'll get it.
Okay,
Yeah,
that's it, all right.
So this is a tool. This is all the data of 2010.
You don't have to get too close. These are great
Yeah.
mics.
So this is the data of 2010 only. We have finished all the training in January of 2010. So we have started collection of data from this. We have done the retrospective collection of data also. But in the government setup, we don't get too much of quality retrospective data of last 3 years. There is no document at all in any medical colleges about maternal deaths. Because there is a death, but the cause of death is something else, cardiorespiratory failure. Death is not because of PPH or any other cause like eclampsia or something else. So it is very difficult to get that morbidity and mortality data of retrospective. We have done it, but reliability is a big question mark. So what we have done, instead of assessing what is there 3 years before, what is there in the past, before we start the project, we have started analyzing the trends on monthly basis. Instead of comparing it past, what is there in the January of 2009 and what is there in 2010 on a monthly basis. So we have done it on quarterly basis. Quarter 1 AMSTEL data is not there because in the quarter 1 we have finished the training. So these are the facilities where following all the 3 steps of AMSTEL. So this is in percentages and it is increasing. We are working in 55 facility in the 4 states. The facilities are 55 only, including tertiary, secondary and primary care. And the case fatality rate is, of course, we have analyzed the deaths. So what is their death in the first quarter? Naturally, it is coming down. Because quality of care is increased at the tertiary care level. Management at the periphery is increased. Because of task sharing, all the ANMs are trained. At least they know oxytocin injections and all the 3 steps of AMSTEL. So during the referral time, the chances of shock is very less. Because 3 hours transport time is very large time. The energy applied or not applied, that's another thing. But AMSTEL is making difference everywhere. So that is how this mortality is decreasing. And nowadays, because of government is upgrading facilities and blood storage unit in everywhere, now the blood is available. The people are trained with the AMSTEL, B-Lynch or any surgical method. So that is why the mortality is decreasing in our intervention facility. This data is of 55 facilities only. So that is how the case fatality rate and proportional mortality rate is decreasing. Yeah. Another question is about the budget. The scale up of the project, the success is when there is a funding is from the government. Now we are providing only the garment to the governments. Now the government is training to all the 10 district service provider. You can calculate the cost of training of 10 district service provider. One district, there are 500 service providers, even not including all. We are just training 4 doctors and 8 ANMs per facility. If the government is training to all, you can imagine the TADA, transport costs and staying costs. It's a residential training for 3 days. Technical assistance, monitoring and evaluation. In Indian terms, it is 1 crore rupees, and in USD, that is 200,000 USD per state. It is not national figure. This is per state in Tamil Nadu, Rajasthan, Bihar, and Maharashtra. And that's a little bigger achievement for us for the scaling up. Yeah. Oh, all a question for me?
We'll see.
Hi, I'm Madeline Taskay from Women Deliver. I have a question for you, Dr. Shanaz, on your presentation. When you were talking about the referrals of the women once they've reached the 500 milliliter state, where is the communication coming from? I guess I'm curious as to how many of these women own mobile phones and how those families sort of coordinate that communication. Have you done any research on that or data collection on how the women actually call the referral center and access that through communication technology?
Okay. The question about how many women has these mobile cell phones it's all of these, as I said, 8,000, all of them, we have very detailed data in it. And wherever the women, it varies. Like I can go back to all this 8,000 data set and tell you, but most of the cases is when they don't have a mobile phone themselves, they have somebody in the community who has a mobile phone. So it's not that just one approach is working, there are various approaches to it. So community, key people in the community, when they come for the meeting, they actually give them mobile phone numbers and also kind of commit that, if there is any referral needed, their mobile phone can be used for this kind of referral. So it's a very big thing. In 10 minutes you cannot cover everything. Maybe, like we can just tell you details. So we have a list of all the mobile phone numbers in our data system, all the key leaders who want to be involved, and the service providers. So what we do is the woman that is visited on her first visit, or she comes to this meeting, she actually says which area she's from, so she gets the service provider's mobile number. And also the referral centers, which we have assessed and set up, and they're aware of this project. They're working with us to make sure that PPH does not occur in their project area. They also has volunteered their mobile phone numbers to be used by the mother or the service provider or a community person to let them know there is a woman who is suffering. And the referrals is basically, it's a call, but then the distance has to be traveled. So usually it's a community coming together, or the woman herself, her family, not the woman herself, the family can get some transportation arranged. And then top of that, what we have done is, because it's a very small area, maybe I don't know when it scale up what is going to happen, but we have actually given an ambulance to the hospital. So that is specifically just for cases like this. So in that ambulance, the driver has the phone number also. So there are a lot of elements, and if you really have to go in and see which is more effective, but we don't think a single approach is effective. It is the whole package which has to come into play.
Okay, there was another question over here.
Thank you. My name is Ndola Prata from Venture Strategies Innovations and University of California, Berkeley. And I would like to congratulate all the presenters, and I also have some follow-up questions for Dr. Shehnaz. What I would like Dr. Shehnaz to explain to us a little bit is the challenges in implementing a safe delivery kit distribution to such a large number of women. And I would like you to explain a little bit in terms of the challenges that you face with reaching 8,000 women, and what can we expect if we have to increase the population to scale up. And specifically in terms of transportation, to basically bring the safe delivery kits to those villages, the distribution, the storage. What are the issues that we need to have into consideration when thinking about scaling up distribution of safe delivery kits? And one more question is, the safe delivery kits were distributed at 32 weeks gestation. And can you tell us if you had any difficulties for women that did not come at 32 weeks, they came before for antenatal care, and then had to come back for the safe delivery kit? Did they come back voluntarily, or were there any active sort of a pursuit of making sure that these women receive the safe delivery kit? Thank you.
Okay, there are quite a few questions.
A lot of questions there.
The first thing is, yes, I said the safe delivery kit has been around for a long time. It's not a new technology. And you're very correct. There's a lot of challenges to really make sure that all these 8,000 women got the delivery kits. We actually assemble these in the area, in the district area. It's easy now because it's in a small scale. But if you look at the future, and if you really think about it, this has to go into a more commercial production. And social marketing company is already doing that in the country. And what we're now trying to do is, but the social marketing company has not been very successful in creating the demand. So what we need to do is actually combine these two if you really want to scale up. So, when we are doing these interventions or this kind of projects, we always have to think it is not just us. They can be the public system, also the private, and then also social marketing system, which has been successful in other countries. So why not? And in Bangladesh, and also if they could do it for contraceptives, safe delivery kits, I don't think it's any different. So we are already in a dialogue with them, and we have already spoken with them. Like, you have the product, but we know how it works, how we can get it done, and that can be easily matched up, and we can talk about it. This is all the dialogue I already started. I definitely don't see to assemble, millions of kits like this at the community level, because it has not worked before. Because BRAC has tried it, there's other organizations who have tried it. It has not worked. This is number one. And the other thing about which one was it? You want to know about misoprostol? Okay, the storage is, I think once, now it is easy for us because it's a smaller scale. Storage, it's all, every month, because we have the data system, we know the EDD of, expected date of delivery for each mother, and by 32 weeks, we know how many bags we have to make. But once it goes into commercial and you can get it off the shelf, I think that is something about the whole strategy of how you have to create the IC materials, all the BCC materials and the messages which need to go out. I think it's almost the same. You can take the same route that ORS has taken in Bangladesh, because the history is there. How ORS, which started from teaching mothers how to really make the solution to being a commercial product. That is what you really have to think about. That is what it should be. The other thing about misoprostol, which you asked in the 32 weeks, what happens, if they come once and they don't come in, do we actively follow it up? Yes, we do. Because here we are using government field workers and also NGO field workers. This project doesn't have its own staff. We work with both. As I said, the approach has been include and involve as many workers who is out there. We also use not only health workers, to a point we also use other development workers who are out there in the field, regularly have connection with the home, has linkages with all these homes. So, it is really a very big community network which we have established out there in the field, which is necessary and that you can let go.
I have one comment. Susan Collins, I work with Cathy Solter, who's the technical lead, so I help the cross-country coordination. And there was one story that came out of Bangladesh, and it sort of underlines the importance of listening from the project, and where the first bag that was developed was actually more attractive than the one you see now. But what they found is that, thank you, Kelly, that it was so attractive that it was being put to other uses, and so the products were taken out, and kids would use them for school backpacks and things like that. And so you have to have it acceptable, but at the lowest level, so that the woman actually can keep it intact, for the purpose for which it was designed. And that was one of our lessons learned. So there are other examples of that too, but you really have to do follow up on how your technologies are being used in practice. The other one that Shabnam you might want to mention is like the use of the mat as well. It's designed.
Yeah, as I said, 10 minutes is so short a time. Okay, the mat, I really must say, this follow-up has not been just the woman, it is all the materials that we have given, and it has gone through a lot of modification. We also found this mat that I showed you, it is recycled. We didn't tell them to recycle it. What they do is, because usually if a mother does not bleed doesn't really bleed that much after delivery, so the mat is with her. She just cleans it up and reverses it. See, the one side of the mat is cloth, the other side is plastic. So what happens is she uses it for the baby, because you don't have diapers or Pampers in the rural area. So they use it to carry the baby. And so we found this, give technology to women and they'll turn it into something more useful. And women, this is why it works best with women. The other thing is, one women when they use it, we're not really encouraging this. We're going out and telling them not to. Sometimes they just give it to the other person saying, it saved my life. Why don't you try? You should be using it. The women we are not reaching, not within the catchment area. So it happens.
Okay, Debbie, did you have a comment or question?
Well, I do, but I think you need to get your questions first, but I would like to make a statement before we finish.
Okay, John.
John Townsend, Population Council. I think the presenters have done a spectacular job showing that things are feasible at a moderate level. The question is, how long would it take to cover the 4 states you're working in, and about how much money would that come from? And that would be mostly government, I imagine. But thinking about where's the end state? How long will it take us to get this very good model with good implementation practices at a scale where we will see a significant reduction in deaths? That's the first question. The second question has to do with, as you see the drop in deaths from postpartum hemorrhage, what's the transition into the next significant cause of death? whether it's hypertension or sepsis or something else. So how do you begin conceptualizing that and mobilizing the larger safe motherhood community to not just focus on a specific cause of death?
Regarding your first questions, definitely there are a lot of challenges initially. We have started this in 2008, and these are the results in 2010. Initially, even to organize a simple training of 20 size batch, there is plenty of difficulties because this is a 5-day training module. To get the 5-day for all the doctors and A&M from the facility is very difficult and very tough. So that is the reason where it takes 2 years to complete all the trainings, health system in a place, logistic in a place, trained persons, everything. Lot of challenges. It's not so easy in the government of India to work with their other health priority and putting up just one thing, because the 15 days, all the service providers in India are busy in attending all sorts of trainings. Simultaneously, there is induction training, in-service, pre-service, emergency obstetric care training, BMOC training, SBA training, plenty of training, and there is another Pathfinder training of 5-day training. So it's a tough task. That is one during the training. After the training, to get the information, to get the quality data. Initially, we had a big complex format, 3-page formats to collect the information. And I don't know how we have expected that service provider will give us. Because of this National Rural Health Mission, nowadays every facility has 50 to 60 deliveries per day. You can imagine the workload on the service provider. And we are expecting that that service provider is giving 3-page format for each case of PPH. It's completely not possible. So instead of doing all these things, we have just, what is required for us? What is the outcome of this project? To reduction of, what is the goal? To reduce morbidity and mortality of PPH. Not so many stuff which is required. So what is important to convince the service providers, policymakers, hospital in charges, if you use properly the Armbruster, definitely there is improve the quality of care and definitely mortality will be reduced. That's our main goal. So instead of calculating maternal mortality rate, the denominator, it's difficult to get it. We are focused only on the hospital mortality rate. Nowadays, in our intervention facility, hospital mortality rate is 250 per lakh live births at present. So how we are thinking of is the important causes, like at present in our facility, the PPS death was initially is very high compared to eclampsia, septicemia, obstructed labor. Now we are selfish enough to collect the information from the PPH only, PPH point of view. If you go into detail of eclampsia, septicemia, of course, to calculate proportional mortality rate, we have to collect all the information of all the deaths. Initially, nobody is going to share the information with Pathfinder. With the confidence building measures, continuous liaising with the government, at least they are going to show the register. It is very difficult to go into the labor room and to ask what are the causes of deaths. There is a lot of punishment in government of India. So there is a clinical audit, verbal autopsy. So why they share the information to the Pathfinder and inviting us all the troubles? So we first develop that rapport. We are not going to complain anything else. It is just to assess the impact of the program, assess the impact of Armbruster. People have started sharing this information in 2009. I already told you, retrospective data collection, we have wasted 3 years to collect that information, useless. Because maternal mortality rate in 2007 is much higher as compared to this, or much lower. Some facility has 300 deaths, some facility has 1 death. So it's very difficult to rely on that information. So instead of this, we have relied on monthly collection of data, because we have to show some data to the government to expand the project. Otherwise, just calculating maternal mortality rate and ratio, it's very difficult. So that is why we have just shown the trends. What is Armbruster and what is CFR and what is proportional mortality rate. So that is why we have done and we have succeeded. Government likes all this information because they have cross-checked this information from their side also with the Foxy and with the private practitioners. This is credible information which we have taken it from their register. So that is how we have succeeded it, I think. I have addressed all these questions.
You're in the right.
Rashna Raoji with USAID Washington. Deborah, it's great to see you again. And my question is to you, the red bags are really empowering women to take charge of their birth, delivery and birth. And I think it's something which has been also, you've received a good response from the community. Have you thought about, what is your view about adding some information once the crisis is over and the woman is safe and the baby is safe and everything, is putting in information for LAM and for family planning. Because this is something they take it seriously. So I don't know, what would you say, or what are your views about it?
Well, you know, like, again, Cathy, you should have given me 1 hour to talk about it. There is another piece there. There's another small leaflet there.
Oh, was that the piece of paper that fell out? Oh, or this one?
Yeah. Thank you. You're very correct, Roshna. This is actually this kind of question I was expecting, because why a missed opportunity with the bag? I didn't really show this. This is a leaflet we give the mother, and on one side it has the detail what she has to do for the PPH, how she uses the content of the bag. And this is not just given to her, she's actually taken through all the steps. And on the other side, it talks about breastfeeding, talks about postpartum family planning, and it talks up to immunization of the child. Because, you know, like, it's like taking away the, you know, two things apart. And if you just give this for the mother, but we are saying this is for the whole. If you're alive, you're well, but then you have to keep on making sure the baby is well also. So this can be expanded further, and then I think it is very complete. It has the mother's registration number, the child's, and also to the point it also has where they should go for immunization next. So it is also make sure mother goes for her checkup. For the BCG, when the mother goes, that is when you can catch her and do the postnatal checkup. So it is there.
She's ahead. Okay, I'm going to stop questions now, but we'll have more questions later. But I know Deb, you wanted a comment before we finish.
Yeah, I was actually thinking, and that's, I would have probably done my presentation differently. I thought we got to do a little bit of our own reality checks on, especially with active management, which has been around for so long. So a few things that I just wanted to throw out there. I mean, we did talk about it's been around for 20 years. But have we thought about the fact that, you know, in some of these countries, Bangladesh, Tanzania, Uganda, and Ghana, they've also had this information. What about pre-service? Why haven't they been trained in this? We've been putting money, USAID has been putting money, big money, into a lot of these countries. What's happened here? I mean, we really need to think about why it's not working. Central America, all of those countries had been, in another project, working on Amstel using oxytocin as a proxy. They were showing magnificent Amstel in those countries. When we actually looked at it, we didn't find the Amstel practice, even though they were using the oxytocin. So again, we need to make sure that we're looking carefully. Indonesia, interesting information. We, the one bar that I didn't talk about was we actually did a look at home births in one of the districts. It's the only place we did it. Come to find out, and this did play out across most of the countries, the more highly trained the provider, the less they used active management. Physicians, the worst. Now, Iwan, my colleague in Indonesia, says, no, the docs think they know what to do. They got a problem, they can solve it. But the best people in practicing it were the lowest level trained providers. So what does that tell us? You know, and think of how many facilities, you've got your docs, they go to sleep. You've got your midwives, they often go to sleep. Who's doing the births? The assistants. Do they know what they should be doing? Are they trained in active management? Mali, they actually did get trained because the midwives were smart enough to realize that. Surveillance. You know, this whole issue of nobody looking at the woman. Now, we've put massage as step 3, or, you know, palpation. If we could only get people to do that. But, you know, how do we get people motivated? How do they get held accountable? You know, we've got a lot of work around that stuff. It's not just drills. It's not just any of this stuff. We need to be really thinking about what we should be doing. And I want to, you know, got a lot of other things here, but I will end because I know we need to. There are some exciting things going on. They're small right now, but we need to watch them. And I want to emphasize the importance of local ownership. I think you see it here. I think we're seeing it in the transfer of, it's the HCI project from Niger, where they've done amazing work in ownership of a quality improvement program. It's moving to Mali. Now, I used to say, you know, Niger, they've been working there for 8 to 10 years. So, you know, that's a long time. Okay, what do you expect? In Mali, it's just starting to go. I want to watch and see how it happens. but they've been figuring things out. So how do we move this more quickly? How do we truly scale up? Because we all have our little projects. How do we, in a big way, support the MOH to do that? And we ignore, there's a lot of clinicians in the room, we don't look enough at behavior change interventions. We rely too much on training, and we've been talking about this. We need other ways that we should be thinking about it. So I will leave it with that. That's my reality check on AMSTL.
Perfect. Thank you. Thank you to these three panelists. We've got more coming.